It is a challenge for decision makers to allocate public resources to healthcare in an efficient way. Health technology assessment bodies can support decision-making by providing recommendations on the value of new health interventions, such as screening or drugs, compared to usual care. Assessments measure the differential in cost and effectiveness. Effectiveness is defined as the clinical added value in real life of an intervention as compared to usual care. Health technology assessment bodies rely on the cost-effectiveness plane, where the horizontal axis represents the difference in clinical effectiveness between the intervention and usual care, while the vertical axis represents the difference in cost compared to usual care. If the intervention considered falls in the northwest quadrant or the southeast quadrant, the decision is simple. In the northwest quadrant, the intervention is less effective and more costly. Therefore, the intervention will not be recommended for adoption. In the southeast quadrant, the intervention is more effective and less costly. Therefore, it will be recommended for adoption. Interventions in the northeast quadrant are characterized by increased cost and increased clinical effectiveness compared to usual care. To recommend adoption, additional information is needed on how much governments are willing to pay for the additional benefits brought by the intervention. Interventions in the southwest quadrant are characterized by lower cost and lower clinical effectiveness compared to usual care. To recommend adoption, additional information is needed on how much governments are prepared to give up in terms of clinical effectiveness in order to generate these cost savings. These interventions are described as decrementally cost-effective, and they are the focus of this experiment. Because of the potential health losses, DCE interventions are rarely, if ever, considered as an alternative to usual care. Yet, cost savings could potentially be reallocated and used more efficiently to improve health of the overall population. In this experiment, you will be asked to give your preference regarding the adoption of DCE interventions. Your answers, together with those of other respondents, will provide us with a better understanding of the challenges faced by decision makers in adopting these interventions. For this experiment, we ask you to put yourself in the role of a local health officer in charge of a population of 10,000 patients suffering from a specific condition. As such, your mandate is to choose the intervention that will be adopted out of a set budget of 100 million euros per year. Note that the experiment relies on three premises. Firstly, a reference treatment exists for these patients and we refer to it as usual care. Secondly, patients' organizations have been involved in the evaluation of the health losses. And thirdly, scenarios do not involve patients experiencing end-of-life care. You will first be asked to systematically choose between two different DCE interventions. These two options are described by three attributes which differ in their levels. There will be 9 different choices based on a random allocation technique to retrieve the most essential combinations of attributes and levels. Once you have chosen your preferred option, you will be asked whether or not you would be ready to substitute from usual care to the selected DCE intervention. Note that the choices do not correspond to real cases, they are hypothetical situations. We are interested in your personal preferences in your role as a local health officer. And remember, there is no right or wrong answer and no need for previous experience or knowledge on the DCE interventions. We will now introduce the 3 attributes of the DCE interventions. Attribute 1. Health loss. In this experiment, health loss refers to the loss in quality of life as perceived by the patient population due to the adoption of the DCE intervention. This could take the forms of side effects such as coughing and/or additional constraints associated with taking the treatment. For example, a pill every day rather than every week. There are 3 levels depending on whether patients perceive the health loss as being very low, small, or significant. Attribute 2. Reversibility of health loss. This attribute indicates the possibility, expressed in time, for patients experiencing a health loss to switch back to usual care. This attribute has 3 levels: possible at any time, possible after some delay, and hardly possible due to long delays. Attribute number 3, cost savings. The attribute indicates the annual savings being made when switching from usual care to the DCE intervention. The savings are defined as a percentage of the fixed healthcare budget equivalent to 100 million euros per year. The attribute has 3 levels. 5%, 10%, and 15%. Contextual information and options. The DCE intervention relies on the following criteria being fulfilled and unchanged for all the choice sets. Disease severity of the patient before the treatment is low. Uncertainty related to the expected cost saving is low. As mentioned before, in each choice set you must choose which option would be the most acceptable to you by checking one of the 2 boxes below in the option description. After having chosen your preferred option, you must then decide whether you would be ready to switch from usual care to the DCE intervention you just selected. You also have the option to explain why or why not you chose to adopt the selected DCE intervention. For some choice sets, the contextual information will change and there will be 2 additional follow-up questions that might affect your decision-making. You are now ready to take on your challenge as a local health officer. The estimated time to complete the experiment is approximately 20 minutes, and you may save and return to the questionnaire at any time if you wish to continue later.